What's going on, podcasting world? Welcome back to another episode of the Core Consult RX podcast. And we're getting ever so close to episode 100.
Yes, we are. And in honor of that, we decided to pack out our studio as full as possible.
Yes. This is the first time since episode 2 where we don't have enough microphones for everybody.
You know what that means?
We're going to order another microphone. Literally doing it the second we get off the air.
Not surprised.
Don't tell my wife.
No, yeah. I'll keep it myself.
But so today besides Cole and I, we have our buddy Ryan Rosenblatt coming back at you quick.
This is his second appearance?
Second, and then also he's been with us in spirit over Instagram.
That's
probably 8,000 times.
True.
So you've probably heard his name mentioned at least a few episodes.
You guys definitely are the only account I have an alert set up for. Whenever you go live, I'm earning that badge of biggest fan.
Feels special.
I've actually noticed that in my analytics that you're creeping up there towards the top.
I'll get you a sticker.
I'm going to block your account.
Thank you.
Yeah, I'm just kidding. Ryan,
it's an honor.
Happy to have you here. You're on the last, 10 days of pharmacy school?
That's it. Yeah, I end March 31st, and then I have to study for NAPLEX, and hopefully with all this craziness in the world, I'll be able to take it ASAP and sit for boards and sit for the MPJE, and that'll be a wrap.
So they're gonna let y'all graduate?
Well, we'll see.
Good.
And also, I have my 2 fourth-year students who are in Ryan's class that are stuck with me all month of March. First up, Morgan, what's up?
Oh, hey, I'm Morgan. I'm a fourth-year pharmacy student at MUSC with the pleasure of being on my rotation this month, so it's a good time.
So, Morgan, what are you doing come next year?
I'll be doing a PGY1 residency at Wake Forest Baptist Health. So
nice.
Heading up to Winston-Salem. Pretty excited about that.
That's awesome. What's the residency, which residency are you going to be doing? So, general, and then you can specialize?
PGY1, yeah. I'm interested in, internal med, crit care, something like that. So they have PGY2 in both of those. So hopefully I'll end up there for a second year. That'd be cool.
Would you prefer to stay in the same spot for second year, or would you want to go somewhere else if you had to?
I mean, I've heard it's pretty great, so I wouldn't mind staying in the same place. But if I had to go somewhere else, I would.
Be cool with that?
Yeah.
Leah, what's up?
What's up?
Tell the internet all about yourself, because I know you like talking.
Oh, yeah, it's the best. I am also a fourth year, and I'm going to Utah next year for my PGY1.
Nice.
Yeah, a little far away. It'll be good.
I visited there in September. Remember? And I think Mike made... Never mind, we won't revisit that. But
Did I make a joke about it?
You might have made racist comments about Utah.
Racist?
If I recall.
I feel like it
on
was.
On the podcast.
How could they have been racist?
We'll go back to that. I think it was when Patrick was here.
Okay, maybe.
Yeah.
Congratulations to both of you guys, by the way.
Yeah.
Congrats.
And our class has done really well. I've noticed that we've had a lot of people matching first round, so it's pretty amazing. I was always pretty sure that we were smart people in the classroom. I didn't do a residency, but I'm pretty excited to see everybody moving on and doing that. It's been pretty impressive.
We were we got really high up as far as our rankings and with percentage of match, right?
We've been high for the last couple of years, I think.
Yeah, we were number 1 3 years ago.
My year we were number 1.
Yeah.
Nice. Good job, Cole.
I didn't do it, but good job to my classmates.
So, hey, what are you going to do? Are you thinking PGY2 as well?
Yeah, I'm thinking emergency medicine right now.
Nice.
Yeah.
That's cool. You're going to try to stay out in Utah as well? You're going to try to go somewhere else PGY2?
It depends on how cold it gets, to be honest.
It snows.
Yeah, no, it was snowing in February when I went, so I hope I'm prepared.
We'll have to get you hooked up with our buddy Brian Gilbert. It's been on the podcast a few times. He's in emergency medicine. He runs the PGY2 residency for crit care emergency medicine out in Kansas, but he knows a lot of people. So,
yeah, it's basically the same thing. It's out there somewhere.
Yeah,
so.
it's basically the same.
Pretty much the same
state.
place.
You got to fly there anyway. So.
Yeah,
right. You might as well go a little bit.
Why not have a connecting flight in Kansas?
I always find myself out in Kansas.
Yeah, with your ruby red slippers,
Dorothy.
Oh yeah, good Wizard of Oz reference. Well done, boys.
Nice.
That's all I got for Kansas.
All right, so we got a full house today. So I'm interested to see how crazy this looks on the camera.
That's
for the
gonna
video
look
version.
great.
Yeah,
everybody wave.
But there it is.
No, we're supposed to pretend it's not there.
Einstein's throwing off the focus because he's waving.
He hasn't gotten much sun recently. There he goes. Man.
Yeah.
Yeah, he needs some sun.
Yeah, we need to get him outside.
Okay.
So, yes, today we are talking about sickle cell anemia. This is one of those topics, like many of our other topics, where we're like, hey, we should do, a quick episode. Let's take a super complex issue and try to pretend like we can talk about it for 30 minutes.
Yeah, I feel like we could take one piece of this as far as complications go and do a nice 30, 40-minute podcast.
I agree.
We're not going to do that today.
No, we're not.
We're going to talk about all of it.
We're going to do it all. So we're going to go completely against reason and do it the real fashioned way. So I think we were actually was mentioning this to Ryan earlier over the phone. I'm like, I think, now that we're coming on episode 100, I think our big, move after episode 100 going into the new season, if you will, is going to be taking all the subjects we've already done and then actually like going deep with them. And then we can actually, do what we're supposed to be doing.
Yeah, I think that's a good idea.
We had a good warm-up, 100-episode warm-up.
Well, after we've done overviews of every possible medical topic,
Right.
then we have to go deeper.
We have to go deeper. There's no other choice.
The first 100 were free.
You got to pay for this.
Yeah. So much gold in these next coming episodes.
Get your pocketbooks out, America.
Is there going to be a Core Consult OnlyFans? Is that what you're thinking?
Ooh, I don't know. We have a Patreon account, that's about it. It's like -3 people on it. Yeah, we haven't gone the whole pay as you go route yet. I don't think we're going to, especially since most of our listeners are students. I try not to take money out of students' pockets when they don't have any.
Take the government's money.
Not my style.
Now that we're graduating, we can say these because I've definitely learned most of the stuff that I needed to for tests off of your podcast more than anything else. So.
Might not be a good thing.
Do not tell that to anyone at the school. That will not go over well. So, Cole, I'm assuming you got some background information for us?
I do.
He's like the historian of the group.
Did you know that it wasn't
Probably
always
not.
called sickle cell disease or
didn't.
sickle cell anemia? It used to be called Herrick's syndrome. And that was named after a man named James Herrick, who first recognized the sickle cell blood cells in a medical student in Chicago. He was, I believe, teaching at Chicago at the time. The kid was from Grenada, and so which is in the West Indies. The disease we'll see is most common almost exclusively in people of African descent, but also in the West Indies and other areas where malaria is endemic. But James Herrick, he was the one who first found it. He also was one of the first to describe the mechanism of a myocardial infarction of an MI. So he had some considerable contributions. This was in 1910, so just over 100 years ago.
Yeah, that's great. Did he also, was he involved with the genetic component of it as far as figuring out what caused it?
They actually reference that. So he was not closely associated with genetics, but since his discoveries happen to have strong genetic components, he's considered somebody who's contributed a lot to genetics. But no, he didn't look much into it, and I don't think they had too much info on it at that time. He just recognized that, these cells look kind of funny. Yeah, maybe this is why this guy's having so much pain.
That's what I do. I look at cells and I'm like, these don't look right.
Doesn't look
And
right
I make
to me.
discovery after discovery. So, where do you want to start?
Yeah, I mean, we can just start with kind of a little bit of the pathology behind why it's sickled. And we'll say that this is definitely a very sad disease. Most of you are probably familiar that it's kind of an adaptation to create a defense against malaria. That's why I referenced malaria. Believe people who are born with this, their survival rate from malaria is around 60%. But then, of course, they have a significant morbidity if they make it to adulthood and then throughout their life, which is inevitably shortened, even with American medicine, much less someone in a developing country. So definitely a sad disorder. But sickle cell disease, it's primarily genetic. There's multiple variants that can cause it. In America, it's most frequently from variants in the hemoglobin S. That's the most common one found in North America. It's frequently homozygous hemoglobin S, so it'd be references HBSS. It's an autosomal recessive disorder. Like I said, first described by Mr. Herrick, or I should say Dr. Herrick, back in 1910.
And there is several other, I guess, because you can be a carrier of the sickle cell trait, obviously, and not have necessarily any outward phenotypic manifestations of the disease. But that being said, there are several other components that can happen with like where you can have sickle cell plus thalassemia. There's lots of different syndromes that can kind of come about by it, but sickle cell anemia, the one that we typically think of, is the most common form.
That's correct. And
that
they estimate that about 8% of African Americans carry the sickle cell gene, with about 100,000 people in the U.S. actually having full-blown sickle cell disease. So about 2 million Americans in the U.S. If you're in the U.S., well, I guess there are people in the U.S. who aren't Americans, but yeah, 2 million people in the U.S. carry the trait. So,
in thinking that like kind of the whole process, we have a very high concentration of fetal hemoglobin, like during the gestation period, and as around 32 weeks gestation, we start to switch from the production of for gamma chains, from gamma chains to beta chains on the hemoglobin molecule itself. So you get this hemoglobin A production, which is more like the adult hemoglobin that we think about. And so the defect kind of starts all the way with basically just a substitution of 2 amino acids. So instead of valine, you get substitution of valine for glutamic acid, and it's on the 6th amino acid of the beta polypeptide chain of a hemoglobin molecule, and that causes the red blood cell, instead of having that nice like biconcave shape that we always think about, that's very able, to squeeze through capillaries and kind of move around the body. This kind of gives us like this sickle shape, and that can cause, a lot of problems, with vasculature and with several other things we'll kind of talk about. But that sickling is kind of what starts something as simple as a amino acid substitution.
Yeah, and it causes changes in solubility, molecular stability. If you're looking at the chain, it would be designated, instead of GAG, which is what you're supposed to have, it would be GTG for the substitution. So you'll see one of the drugs that they use to treat this, like as a chronic medication, is promoting hemoglobin F, which helps kind of go against the hemoglobin S and the sickling. So we'll talk about that later, but that's one thing that you use to promote that. And I think that's one of the primary targets of new drugs that they're looking at to hopefully prolong life and prevent morbidity in these patients.
And so, if you think about like the sickled red blood cells kind of moving through the vasculature, the endothelium, you can get this endothelium activated by these sickle cell red blood cells. They can bind through like adhesion molecules on the red blood cell surface. They can work through like plasma proteins. So you'll see like von Willebrand factor, things like that. And basically can start this kind of like cascade of activating things like neutrophils, monocytes, natural killer T cells, and then starting to generate other like cytokines, even platelets and things like that. And you get this kind of like endothelial damage that can happen over time and end up causing like a lot of pain in the patients as these red blood cells are trying to move through, and they're causing a lot of other issues around the body. And so kind of getting like lowering the occurrence of some of these crises is one of the main important parts of treating someone with sickle cell disease, and making sure that they're not having this vaso-occlusive crises that can happen with this buildup of these red blood cells. Long-term aspects, that can lead to not just like pain or a vaso-occlusive crisis that we think about, but actually like, things like stroke. It can obviously cause long-term anemia. It can cause things like renal failure, priapism, blindness, lots of different very negative outcomes over time. Mm-hmm. And so it is something that, these patients have a lot to deal with kind of through their entire lives. It's definitely a very painful disease, and something that is greatly decreases their quality of life. Yeah,
and I mean, just to finish out the list of issues they have to deal with, you mentioned acute and chronic pain, bone pain, aplastic crises, splenic sequestration, infection is a big one, growth retardation, being underweight, hand-foot syndrome, which is like where they have swelling of the joints of the hands and feet. I think they call it dactylitis. Acute chest syndrome, which is a frequent cause of mortality in children. Pulmonary hypertension. Avascular necrosis of the femoral and humeral heads. They have CNS, ophthalmologic, cardiac, GI, GU involvement, various things. Dermatologic involvement. They get leg ulcers, which is a chronic painful problem. So lots of things. So we could probably take 2 or 3 of these post episode 100.
Right.
And actually
Not
talk
a
about them
second
more.
sooner than that.
Nope. Not 99.
I think the pain portion of it is probably the most influential. I know that a lot of the patients I see at the pharmacy I work at who are chronic pain are sickle cell. And then on a rotation in the inpatient, we had an acute pain episode, and the patient actually came in and said, I'm going to need this regimen to get through this. She had it already down, like whenever this happens, she comes in, she needs X amount of Dilaudid, and she can make it through the 2 nights that she needs before they can treat her and try to stabilize her. So I was very impressed by that, and very, the doctors were willing to let her drive the boat because she'd done this a few times in her life.
I think too that kind of plays into the whole stigma with the opioid, crisis and things that we're talking about now. If somebody comes in, it's like I need this, strength Dilaudid, I need PCA here, I need all this. It can definitely throw up some warnings like, okay, come on, are you really here to get control of your pain? But it's one of those things that this is such a painful disorder that yes, and you have to take the pain seriously, and it's not just that they're a chronic medication seeker. It's the fact that they have this disease that really is very, very painful.
Right. 2 of the diseases that they frequently reference is like, oh yeah, of course they need opioids, is cancer pain and sickle cell crisis.
Right.
So yeah, sometimes they do seem drug seeking, but all they have to do is look at their history and say, oh, they have sickle cell, and boom, yeah, it's fine, you get what you want. Because frequently they're trained. So if you're being treated for sickle cell, a lot of times you want to be set up with a hematologist, or even go to a clinic that specializes in treating sickle cell, because there's a lot of facets to it, and they'll probably counsel the patient on actually trying to handle their sickle cell crisis at home first, and then if they're like the bed rest and the oral analgesics is not getting the job done, that's when they go to the ER, and I'm sure they have their regimen, like they know exactly what they need to get them through, and the guidelines emphasize the importance of quick assessment and treatment of pain shortly after triage. So yeah, as far as the outcomes from that visit, it's important to get that on board early.
And as far as managing, the number of crises that they have, Cole mentioned it earlier, but hydroxyurea is one of the longest used medications in this disease state. And what it's doing is it's actually increasing that fetal hemoglobin production, like Cole said. Now, as far as children, we typically, consider if a child's greater than 9 months, we're going to consider this therapy and see if the patient's a candidate for it, regardless of severity. It's been shown to decrease the number of painful crises, decrease the number of episodes of acute chest syndrome, the need for blood transfusions. However, the black box warning that we are always concerned about is the myelosuppression. So you can get this decrease of white blood cells, platelets, and even potentially malignancy. It's essentially like poison that you're kind of putting in your body in some way, in some aspect. So yes, it will increase the fetal hemoglobin as high as 50% concentrations, but definitely some serious things to kind of keep in mind. Adverse effects besides that, that are more common would be things like increase in LFTs, can increase your serum creatinine, definitely can cause some GI upset, and even like hyperpigmentation as well. And as far as adults go, it's a little bit different. So with adults, it's more indicated for patients who have had 3 or more painful crises in a 12-month period, or they have like chronic symptomatic anemia. Maybe they've actually had like a disability because of their sickle cell disease, or they've had like recurrent episodes of acute chest syndrome. Those would all be factors that would make you potentially try hydroxyurea in an adult. And I guess in an adult patient too, one other thing to keep in mind would be contraception use, especially if you have a young, 20-something-year-old, making sure, because it has to be, contraception is going to be required during treatment and then after it's been discontinued, for 6 months for females and then 12 months for males.
Yeah.
So.
Yeah, pregnancy is definitely a special area of concern in these patients. High rates of fetal loss due to spontaneous abortion. placenta previa and abruption are common due to hypoxia, placental infarction. At birth, infants are often premature and they have low birth weights, failure to thrive. So yeah, definitely a concern. And it's different in patients who just carry the gene and don't actually have sickled cells, but in patients who actually have sickle cell disease. And back to the hydroxyurea, definitely important because there aren't a lot of long-term options. So you mentioned a lot of issues and side effects, potential malignancy and that sort of thing. But as far as the prognosis in America, it's still not fantastic long-term. So mortality is still high, especially in early childhood. Since they introduced prophylactic antibiotics like penicillin and pneumococcal vaccination, it definitely decreases the risk for infection and dying from that cause. The leading cause of death, like I mentioned before, is acute chest syndrome, and children have a higher incidence of acute chest syndrome, but a lower mortality rate than adults overall from that. There's a couple of mortality studies that I was looking at. So Dallas did a newborn cohort. So the estimated survival at 18 years was 94%. In a recent other study from the United Kingdom, a survival rate in patients with this HBSS at 16 years was 99%. So that's really good. But as far as, the goal is to have them live long-term normal lifespans, the suggested survival, this is from, over 20 years ago, was about 48 years for women, 42 years for men. I would presume that it's higher now, but still significantly shorter than a regular lifespan.
Yeah. One of the studies that I always think about, I just like the name of it, is Baby Hug.
Baby Hug?
It was...
that's sweet, Mike.
Yeah, right? Hydroxyurea was shown to significantly reduce the incidence of vaso-occlusive crises and dactylitis in very young children. But the problem is that like you were saying, the long-term aspects of it are still kind of unknown. It's
interesting because newborns are frequently... They mandate screening for all children now in the U.S. But newborns are frequently protected by their mother's hemoglobin F for the first 6 months of life, which I think is very interesting. But yeah, and that dactylitis was that hand-foot syndrome that we were talking about earlier too.
Yeah. So what are some other options?
Well, it depends on what they're coming in with. So, of course, we talked about pain, opioid options, regular opioids that you would think of. Oxycodone, methadone, morphine, Percocet, fentanyl. Pretty much something will have been tried before, especially if they're older. And if they're not, there might even be a protocol for how to start that at your hospital. I guess you guys who've worked those patients would probably have more insight than me on that.
Yeah, I know when I was down in the emergency department in January, we saw a lot of sickle cell patients. And they generally, there's a clinic connected to MUSC also, so they generally have a protocol already in place.
Yeah, gotcha.
And it's just a matter of looking through their chart and seeing what they're supposed to be on.
Nice.
So
nice.
That's pretty easy from that standpoint.
Good.
At least.
So I guess you start with that, and if it's not getting the job done, you just escalate from there.
Yeah.
The goals of treatment overall, so like I said, it depends on what they're presenting with, but you need to manage the vaso-occlusive crisis. They actually list 7 goals in the guidelines. Manage vaso-occlusive crisis, chronic pain syndromes, chronic hemolytic anemia, treat and prevent infections, manage complications of the various organ damage syndromes, ultimately prevent stroke because they're at a high risk for stroke, and then detect and treat pulmonary hypertension, which it seems recent data is showing that's more of an issue than they used to think it was.
So, kind of looking at some of the other options that we have to reduce the frequency of vaso-occlusive crises in adults specifically. So we have an agent that was approved in November 2019, crizanlizumab.
Nice.
Hopefully I nailed that.
I think you nailed it.
Whew, felt good. So the mechanism of action here is not working on fetal hemoglobin because, again, it's reducing the frequency of vaso-occlusive crises. It's inhibiting something called P-selectin. And that P-selectin is translocated to the area of the endothelial after it's activated in the cell surface, and that's going to actually be what causes that adhesion of sickled red blood cells to the actual vessel, which can start causing damage. So you inhibit that P-selectin, and that process never kind of comes to fruition. And this is given IV, and it's given once every 2 weeks for 2 doses, and then they go to once every 4 weeks. So you get an infusion. And the studies that looked at it used patients that were taking hydroxyurea and ones without. So the studies were called the SUSTAIN clinical trial, which is confusing since SUSTAIN
I've heard
was
that before.
Ozempic, and that's the one we always think about from a diabetes
That's
world.
SUSTAIN 6, or I guess there were multiple, but the series.
There was 1 through 5, then 6.
1 through 5, then 6. Yeah.
No,
Maybe
so
these weren't numbered. Maybe they were.
I don't think they
alphabet.
were.
Maybe it was
Hopefully,
SUSTAIN
A.
Yeah.
That'd be less confusing for sure. But just to give you an example, crizanlizumab was reduced the median annual rate of vaso-occlusive crises, leading to healthcare visits by 45.3% compared to placebo. And again, those patients were either taking or not taking hydroxyurea. So this can be an add-on. But the adverse effects, besides the price, is going to be like neuromuscular pain, pruritus, injection site reactions because of the infusion. And then also the inconvenience of having to actually go get it infused. So it's fairly new in the market. I'm not sure how widely available it is at this point yet, but November 2019 that came out.
I think it's fairly available. I was talking about it. I had to do a monograph on it for the P&T committee on my rotation in January. Yeah.
Did you see people using it and stuff?
They were starting to use it. Yeah,
Nice.
I think they had about 6 patients on it.
Nice.
Yeah. I don't know how, like you said, the price is insane. So, like, long term, I don't know, if it's sustainable, like hydroxyurea was. I think we were just trying to keep people on hydroxyurea for the most part. But
Well, that's the way it is with all those monoclonal antibodies. Someday they'll be like aspirin, and it'll all be cheap, right?
In the water.
Yeah, they'll put it in the water.
They'll be like aspirin and no longer needed.
Yeah, exactly.
Hopefully.
So L-Glutamine is another one.
Yeah, I saw that.
And Dari. So L-Glutamine is exactly what it is. It's a amino acid. And it's used to reduce acute complications of sickle cell disease. So the mechanism of action, last time I checked anyway, it still says not fully understood, but they think that it decreases the oxidative stress, which then can cause damage.
That was always the best mechanism, because whenever I saw that when I was studying, I was like, well, don't have to know that one.
Right.
They don't know either.
Oxidative stress means they don't know.
I'm not gonna put a test question about one that says not fully understood.
Have you guys seen this used at all?
No,
no, I hadn't seen it.
No. So, as far as it's a powdered, oral powder, and you mix it usually with 8 ounces of fluid. It can be put in things like applesauce and yogurt, and they take it twice daily. Adverse effects, GI upset, cough, headache, so pretty mild comparatively, which I guess you'd expect with being an amino acid.
Right.
But still not the cheapest thing on the market.
I saw an interesting one. There was a small study out of Nigeria where they used lime juice supplementation to help with ascorbic acid. Apparently, people who are deficient in ascorbic acid can actually have worsening hemoglobin polymerization, and so it was small. It was only 113 patients, but they did have a significant decrease in painful episodes and admission rates. So that's something to think about, especially maybe if you're dealing with a patient population that's malnourished. You could check them for that type of therapy that may be on the cheaper side, is something as simple as lime juice or something with ascorbic acid.
Yeah, and in lower or underdeveloped countries, third world countries, you definitely see the poor nutrition more frequently, and they mention other vitamins like folic acid. And I was talking about mortality rates in America. There haven't been a lot in Africa. A lot of them are sporadic and incomplete. There was one from 2004 that suggested approximately 50% of patients do not survive beyond 20 years, and most all, so in the 90th percentile, did not survive above 50 years. So long-term prognosis is definitely not as good. So vitamin C can help. That's ascorbic acid, right? Vitamin C.
You
Nice.
got it.
Vitamin C.
Still got it.
Nailed it, man.
No,
that can help.
chemistry.
Then go for it.
So I just looked to double check myself, but the the L-Glutamine can be used either with or without hydroxyurea as well. So as far as like prevention of vaso-occlusive pain episodes, they will use it as an adjunct to hydroxyurea or as an alternate if a patient can't take it for whatever reason.
Nice.
It also is the only one, like that brand, and Dari is the brand name. It's the only one, because there's several other formulations of it available. It's the only one that's, FDA approved for sickle cell. Not to say that people don't use it off label, I'm sure, but yeah, sickle cell disease, it's in Dari is the actual brand name that's used. So Voxelotor is the other one on the market. It was approved November 2019. And it's also indicated for treatment of sickle cell disease in adults and pediatric patients 12 years and older to cut down on the crises and all that. This is going to inhibit the sickled hemoglobin polymerization, which is going to keep basically the red blood cells from sickling. And it's going to also reduce the whole blood viscosity. And it's given orally. It's oral medication. GI upset, nausea, abdominal pain, things like that. And this is another one that can be given with or without hydroxyurea as well. So it's another adjunct potentially. It is a substrate of CYP3A4. So if you have a patient that gets put on this, you got to watch the drug-drug interactions, but also newly available.
Yeah, as far as other issues, because there's a whole host of them. Priapism is one that can definitely be a concern, and Morgan pointed out that Sudafed is an option to treat that. The reason they have priapism frequently is because of the red blood cell issue and the vaso-occlusivity. They have issues with blood flow, and they can have priapism. The Sudafed can promote vasoconstriction by directly stimulating alpha-adrenergic receptors and potentially help with that.
Yep.
I think it's always...
Yeah. We used it a lot on my rotation the other month.
It's fantastic.
Very common. I was super confused. I was like, does this kid have allergies or what are we doing? So
Sickle cell crises and the sniffles.
there you go. Twofer.
Treat both of them.
So there's another thing that I know, like Trident Medical uses a lot, just because Scott Bragg's over there on their inpatient area. He uses zinc sulfate, 220 milligrams, I believe, like 2 or 3 times a day. And there's like this Cochrane review from a while. I want to say like 2006, but it may not be right. It's a Cochrane review. What is it, Ryan?
2013.
Shoot.
Dr. Bragg definitely gave this to me while I was with him.
Okay,
so
perfect.
I had it pulled up.
Sorry, I didn't mean to steal your thunder.
You go ahead.
But basically, it's been shown to reduce the annual occurrence of sickle cell crises, and the mechanism, if I remember correctly, is something along the lines of keeping the red blood cells hydrated, and it's something that you'll see a lot of the patients that get put in inpatient in his clinic or his hospital will get put on this as a supplement and hopefully leave on it because it's was fairly cheap the last time I looked.
Yeah, I think that was usually his goal of intervention, was to try to have something as a preventative measure that's not that expensive and maybe could cut back on hospital time and even any kind of these other comorbidities.
There's also some slightly promising data that say that it can help prevent the flu. So you combine that with the Sudafed, you're knocking out like 4 birds.
Right.
Yeah.
Because zinc's super expensive right now.
Yeah, right.
Of, all the
price gouging.
Apparently, there's this virus going around.
Is there?
And that's what I heard.
Man, gotta look into that.
Yeah.
Yeah, I found a case of hand sanitizer in my trunk. It was weird.
It's worth $5,000 right now.
Oh my god.
Yeah.
But the other thing is red blood cell transfusions. So
Yeah.
transfusions are one of those things that they're not typically going to be required for usual anemia or episodes of pain associated with it, but there are certain indications where you would need to have an infusion. So acute infarctive stroke, severe acute chest syndrome, multi-organ failure syndromes, right upper quadrant syndrome, priapism that does not resolve after adequate hydration and analgesia or potentially Sudafed.
Potentially.
Those could all be reasons that a patient would be indicated to get a transfusion. Obviously, there's issues with you have to worry about that, including iron overload, which is fixable but still can cause a lot of problems. So, don't think about it though as far as a routine, thing to do.
No, but you're definitely going to see it more in this patient population than the
for sure
population at large.
Yes. I was gonna talk about some of the preventative stuff, especially in kids. Do you have any other treatment or options?
That's most all I got.
So one of the things you'll see usually is the prevention of pneumococcal infection is a big deal in children. And so they'll do penicillin prophylaxis. So children that are less than 3 years old usually do 125 milligrams of penicillin twice a day. 3 and older, basically 3 and older up to 5 is when this is kind of stopped. They do 250 milligrams BID. And if the child does have a penicillin allergy, then they'll use the erythromycin ethyl succinate, the suspension, BID. And then at 5, they stop that and they don't do any more. Immunizations, so most kids now are going to be getting the pneumococcal series. So Prevnar 13 is going to be given to most children at this point, but the series is going to be given to infants. And then once the child turns 2 and 5, they're going to receive a Pneumovax 23 as well, the polysaccharide vaccine. So definitely give the conjugate first because you're going to get a much better immune response to the conjugate vaccine. And then the polysaccharide, once the kid's a little older, the immune system is a little bit better, then you can give the polysaccharide. And then it's also an indication for a meningococcal vaccine as well. Influenza, starting at 6 months old, give 2 influenza shots 6 months apart for the first time they're getting it in their life, and then annually after that, which all of us should technically be doing. But, and then hopefully the coronavirus vaccine, whenever that gets released.
Might be having that by next flu, or not this flu season, but the following flu season. Might be giving that one as well.
We'll see.
Awesome.
Yep.
Great.
Can't wait.
We weren't doing enough vaccines.
Right.
Man.
And we got two more pneumonia vaccines coming on the market too.
Yeah.
I think next year.
Great.
There's
Are they going to replace
15 and 20 serotype? I think it's Merck and Pfizer.
I guess it won't replace Prevnar. Just I wonder what they're going to do
I
with
think
the
it's
guidelines
gonna,
there.
Well, so Pfizer's working on the 20 serotypes. So I'm sure they're going to use that to replace.
I'm already kind of confused as to what to recommend to people about Prevnar now.
65 and over, it's clinician specific.
Yeah.
Like so, if the
So I
person,
mean, like if they're asking, like me in the pharmacy,
I usually say if a person has diabetes, hypertension, something will put them at
if they have
risk.
anything, then
COPD,
just give it to them.
Sure,
Yeah.
but if it's person's perfectly healthy, they know the risk factors, it's probably not going to do much.
Which is rare.
Yeah.
Well, speaking of COVID-19, so we'll be on
Change.
drug wash for our little coronavirus update. But I mentioned Plaquenil in the last episode.
Mm-hmm.
So yeah, there looks promising for hydroxychloroquine or chloroquine to be one of the contenders for something they treat with. And then Gilead is in phase 3 clinical trials with a antiretroviral.
Yep.
Yeah. The what was it called? It starts with an R.
Yeah, it does.
Remdesivir.
Yeah, remdesivir.
There it is.
So we'll see what happens there. But yeah, 1,000 patients in their phase 3 clinical trial currently.
Did you see they have an inpatient and an outpatient study going on right now with losartan?
Yeah, I saw losartan too.
Yeah.
I still don't understand that, but maybe somebody can explain that to me.
I got a good article I can send you, but it's
Okay.
basically because of the production of ACE2, and that enzyme. If originally they were saying ACEs and ARBs are terrible, it stop everybody, and then we realized maybe that's probably not a good idea. And then basically they were saying that now there's some thought that because ACE2 is the enzyme that basically the COVID-19. This is my very basic understanding of it, can kind of use that enzyme to kind of hitch a ride inside of the cell. And that's what it uses as spike protein or whatever to migrate inside the cell. And so if we can kind of shut down some of that or deregulate some of that, then
So it steals its transportation. Just totally cuts off public transit.
right.
Nice.
And then now they're saying ibuprofen can increase viral replication.
Oh, interesting.
The World Health. So first I got a text from Beju Shah, and he was like, "Dude, check this out." And it was like the morning, and then like literally like that night is when the World Health Organization said don't take ibuprofen. And I was like, I knew before they did. Thanks, Beju. So that was crazy. Lots of stuff. We're gonna have Patrick on here to give us an update from the front lines at the VA.
He's in charge of the VA over there, right?
Allegedly. It must be really slim pickings on.
What a world.
I know, right? That is why everything's happening.
Yeah.
It's happening.
Just kidding. Love you, Patrick.
I'm going to blame him.
So, do we have anything else since we're totally off topic now? Anything else for this?
That's all I got. I definitely say let's do a follow-up. Let's grab a couple of the complications and just
go with it. For sure. We'll do that. But for now, we'll call it good. So thank you guys so much for listening. I know this is a very, very brief and basic overview, but I hope it was somewhat useful. But thank you guys so much for the support. If you have any questions, our emails and other contact information will be in the show notes. And all my new buddies here will be able to be in contact with too. If you're interested in getting in touch with any of them, I'm sure they won't mind us sharing all their Instagram stuff with everybody. And
Sure, why not?
but yeah, thank you guys so much. If you do like the podcast, please subscribe, leave us a comment or a rating. That helps us out a lot. Don't forget to follow us on all the social media platforms, YouTube, hint, hint. That's the big one right now we're going after. And yeah, we'll see you guys next time. Thank you so much.
Good to be back. Thank you.
Yeah.
Ryan, don't mess up my sign off. I'm trying to say bye. Just kidding. Thanks, guys.